The following presentation was recorded at the 2017 ANZICS Safety and Quality Conference.
So I've been asked to address the topic that the ICU doctor should be the primary responder, and I'm afraid I'm going to be a little bit disappointing here. I mean, the real question is whether you should let this bloke out on his own, on the wards, trying to be the first responder. What would be the logic of that? Would it work? Clearly not. The rapid response team is a team. The medical emergency team, whichever term you use, the word team is in both of the titles. It is a team. And the doctor, ICU doctor, is part of the team. The response that we've used, the response that we've assessed in almost all of the studies is a team response, taking a team out and the combined activity of the team. The model that we use and the model that most of the studies have used involves sending an experienced ICU nurse. And I take the point that having a low number of nurses who are highly skilled and highly experienced is magic. Taking someone who's never been on a Met call before is not really helpful. An ICU registrar or an ICU resident supported by the ICU nurse will work. A registrar, I think as we go more senior, what the Met call delivers becomes increasingly wide and effective. And the collaborative effect with the ward team and the ward nurse. So I really can't defend sending the doctor on their own. I can't imagine why anyone would ask me to talk about that. But I'm going to talk about a team. So as a politician, I will just change the question and I will talk about something I can win. So, you know, the team, together, everyone achieves more. We are more than our parts. Together, we can do a lot. A doctor on their own is not going to be as effective, will struggle with all the bits and pieces, will struggle thinking in a way, may not be as collaborative, but together it works. That's what has been proven. That's what's been studied. In 21 of 29 studies in the recent meta-analysis in critical care showed that in 21 of the 29 studies included a doctor on the team. So what they assessed, this is the model that they assessed. There was a nurse-led team in 3, a medical doctor in 3, and either an ED or an ICU doctor in 1, which may have been chaos, and unspecified in one of the studies. The ward doctor review, which will, is appropriate. It's already in the system. The clinical review recommended is in all of the models. This is from one that I picked up just in the ward for you last week, and you can see that there are 2 here, and I can tell you that neither of those got a review. So it's part of the system, but dream on. Now, the problem of including an ICU doctor justifies appropriate medical rostering. If we can call as needed, and I shall certainly be asking Kylie later how many of their calls actually call the doctor, because they're not paying their doctor, they're cheating, and they're just using the doctor they've got, and they're abusing their poor doctors and making them come out to help them without paying them. So it may be cheap, but it's not fair. So calling as needed without resourcing is not appropriate, and the college approach is that there's no negative effect on ICU. So we should stand up. That's what it is. We're complaining there's a massive number of Met calls. Yeah, there's a massive number of Met calls. So why are we trying to do it with nothing? Can't be done. Don't do it. The doctor, of course, may be the first responder on occasion. More and more there's concurrent calls. Particularly if the team have some other things to do in terms of retrievals or taking patients, transport in the hospital, which is common. But having 2 or 3 Met calls at once and having to prioritise does separate the team. And of course they can do it on their own. But the gold standard, the proper way to do it, is the team together. tasks can be very prolonged. You go to a Met call and you can be there half the morning. They can be incredibly complex. And again, one person on their own out for hours is going to be a problem. And certainly in terms of, I just go back to the impact on ICU. Taking people out of the ward round 4 or 5 times during the ward round is highly detrimental to the ward round. And if you don't do the ward round properly in ICU, it's bad for patients. And of course, we have different skill sets. There's much more, of course, to deteriorating patient than physiology. There's a diagnosis to be made, both mental and physical. There's collaboration that's necessary. So good relations between the intensive care doctors and nurses and the wards is an important part. So being good at collaboration is important. Clearly nurses are good. Clearly doctors can do it. Predicting the future. I'm amazed. People go and do physiological sorting out and you think, oh, I sorted out the hypoxia. Well, you put them on CPAP, but what the heck's going on? Do you think this patient is on clearly deteriorating? Did you not see that? What were you looking at? Well, bringing up the blood pressure. Where's this going? And planning, getting the surgeons to take the patient back to theatre, identifying things, making things happen. You need the team. You need to be together to help each other to get that to happen. Negotiating with absolutely everybody, and neurosurgeons, cardiac surgeons, oncologists. It's tough. It's a tough world out there. And of course, that's before I come to end-of-life stuff, which, as I said in my talk this morning, involves, here from the slide this morning, again, to reiterate, 2/3 of the... Oh, God. There we go. Sorry about that. 2/3 of the patients have end-of-life issues. They've got a life-limiting illness when we go and see them. So, we need to be together. These discussions are difficult. Being a team, the task is hard. Going as a team is clearly the right thing. And trying to do it on the cheap for the administrators is not really kind to the administrators, because actually I think the administrators would quite like us to do it properly. And I leave you with that. Thank you very much.